She came in on a Tuesday morning, 71 years old, retired schoolteacher, sharp, careful, the kind of woman who kept a handwritten list of every medication she took, the dosages, the timing, everything. She wasn't careless. She wasn't uninformed. She did exactly what her doctors told her to do. Every single day, without fail. And yet there she was in my office, her hands trembling slightly, her blood pressure dangerously low, her kidneys showing signs of acute stress that had no business appearing in someone who, on paper, was managing her health beautifully. It took me 40 minutes of careful review to find it. Not a disease, not a new diagnosis, a combination. 3 medications, one her cardiologist prescribed, one her general practitioner added 6 months later, and a common over-the-counter painkiller she picked up herself at the pharmacy without a second thought. Nobody told her those 3 medications together were a problem. Nobody connected the dots. And her body was paying the price, quietly, invisibly, until it wasn't quiet anymore. Her name was Margaret, and what happened to her happens to thousands of seniors every single week across this country. Most of them never find out why. My name is Dr. Philip Paulson. I am an internal medicine physician with a focus on cardiovascular health and senior wellness, and I have spent over a decade watching the same preventable pattern repeat itself in patients who are doing everything right. Today, I am going to tell you about 5 medication combinations that become genuinely dangerous after 60. Not because the medications themselves are bad, most of them are prescribed for good reasons, but because the aging body processes multiple drugs very differently from a younger one does. And that difference, that gap between what works at 45 and what is safe at 70, is something the medical system does not always take the time to explain. Stay with me. By the end of this video, you will know exactly which combinations to watch for, what to ask your doctor, and what signs to look for in your own body. Here is something most people do not fully understand about the body after 60. And I want you to understand it before we get into the 5 combinations, because it changes everything. When you were in your 40s, your body had an extraordinary ability to process medications efficiently. Your liver enzymes worked at full capacity, breaking down drugs quickly, neutralizing them, and clearing them from your system on a predictable schedule. Your kidneys filtered your blood at a rate that kept medication levels stable. Your body was, in a very real sense, a well-calibrated machine for handling pharmaceutical compounds. After 60, that machine slows down. Not because something is wrong with you, because this is what aging does to human biology without exception. Your liver enzyme activity decreases by as much as 30 to 40%. Your kidney filtration rate drops significantly, sometimes by half, compared to your peak function in your 30s. And your digestive system slows, altering how quickly drugs are absorbed into your bloodstream. What this means in practical terms is this. A medication that clears your system in 6 hours at age 45 may take 10 or 12 hours at age 72. It builds up. It lingers, and when a second or third medication enters that same slowed system, the interactions between them become unpredictable in ways that simply do not happen in a younger body. There is a term physicians use for this: polypharmacy. It means taking 5 or more medications simultaneously. And according to research published in the Journal of the American Geriatrics Society, More than 40% of adults over 65 meet that definition. More than 40%. Many of them have no idea that the combination sitting in their medicine cabinet right now is creating a chemical environment inside their body that none of their doctors have fully mapped out. That is not an accusation. It is a reality of how modern medicine works. You may see a cardiologist for your heart, a rheumatologist for your joints, and a general practitioner for everything else. Nobody always sees the full picture. That is exactly why you need to. So let us talk about the 5 combinations. Before I get into the first combination, I want to take 30 seconds to mention something quickly. On this channel, we cover a lot of information that is genuinely useful, but only if you can act on it between videos. So I put together a completely free resource called the Senior Patient Toolkit. 2 pages. The first page is a medication interaction checker card. It lists the most dangerous drug combinations affecting seniors, so you can check your own medication list and circle anything that concerns you. The second page is a word-for-word doctor's appointment script. Not tips, actual sentences you bring into the room with you. The link is seniorsaids.com, and it is in the description below this video. It takes about 30 seconds to get it into your inbox, and it costs nothing. Grab it after this video. And if you are watching right now and you already take multiple medications, this toolkit was built specifically for you. Now, let's get into the 5 combinations that become genuinely dangerous after 60. Combination 1. Blood pressure medications and common painkillers. This is the combination that nearly destroyed Margaret's kidneys, and it is almost certainly the most widespread and dangerous drug interaction affecting seniors today. The blood pressure medications I am referring to are a class called ACE inhibitors and a related class called ARBs. You may know them by their brand names: lisinopril, ramipril, enalapril, losartan, valsartan. These are among the most commonly prescribed medications in the world, and for good reason. They are highly effective at controlling hypertension and protecting the heart. The painkillers I am referring to are NSAIDs, non-steroidal anti-inflammatory drugs. Ibuprofen, naproxen, and their branded versions, Advil, Motrin, Aleve, available without a prescription at every pharmacy and grocery store in the country. Most seniors who take blood pressure medication have no idea that reaching for ibuprofen when their knee aches is creating a direct conflict inside their kidneys. Here is what happens when you combine them. ACE inhibitors and ARBs work partly by dilating the blood vessels that supply your kidneys, reducing pressure and protecting kidney tissue. NSAIDs do the opposite. They cause those same vessels to constrict. They also cause your body to retain sodium, which raises blood pressure directly. Put both in the same system, and they are working against each other at the kidney level simultaneously. For a 40-year-old with healthy kidneys, this tension is manageable. The kidneys compensate. For a 68-year-old whose kidney filtration is already running at reduced capacity, this combination can tip the balance into acute kidney injury within days, sometimes within hours of taking a single dose of ibuprofen. I want to be precise here because precision matters. This does not mean ibuprofen will harm every senior who takes a blood pressure medication. It means the risk is real, documented, and almost never explained at the pharmacy counter when someone reaches for a bottle of Advil for their knee pain. What should you do? First, check your medication list right now. If you take any ACE inhibitor or ARB for blood pressure, make a note. Then check your bathroom cabinet for ibuprofen or naproxen. If both are present, you need a conversation with your doctor about safe alternatives for pain management. Acetaminophen is generally a safer choice for pain relief in this situation, though it carries its own considerations at high doses. Topical anti-inflammatory gels are another option your doctor can discuss with you. The conversation takes 5 minutes. Margaret did not have it. She picked up the ibuprofen herself because her knee was aching, and it never occurred to her that it could affect her blood pressure medication. It would not occur to most people. Now it will occur to you. Write these down. Question for your doctor. Given my blood pressure medication, what is the safest option for managing my joint pain? That single question could protect your kidneys from damage that most people never see coming. Combination 2. Blood thinners and aspirin. Warfarin, rivaroxaban, apixaban, dabigatran. These anticoagulant medications are prescribed to millions of seniors with atrial fibrillation, deep vein thrombosis, mechanical heart valves, or a history of stroke. Their job is critical. They prevent the blood clots that cause strokes and pulmonary embolisms. In the right patient, they are life-saving. Aspirin also thins the blood. It works through a different mechanism, inhibiting platelet function rather than the clotting cascade, but the net result is the same. Your blood becomes less likely to clot. Now, combine them. What you have is a patient whose blood has been made significantly less capable of clotting through 2 separate mechanisms at the same time. For most people, the primary concern here is bleeding. Internal bleeding that starts small and is never detected. A small bleed in the gastrointestinal tract that goes unnoticed for weeks until the patient presents with severe anemia and fatigue they attributed to simply getting older. In seniors over 70, the risk of gastrointestinal bleeding with combined anticoagulant and aspirin therapy increases by a factor of 3 compared to anticoagulant therapy alone. 3 times the risk. And the tragedy is that many seniors are taking both because one was prescribed by a cardiologist and the other became a daily habit years ago when aspirin was routinely recommended for heart health. That recommendation has since been significantly revised for older adults, but the aspirin habit remained. Are you currently taking a blood thinner and a daily aspirin? If yes, the conversation to have with your doctor is direct. Ask specifically whether the aspirin is still necessary given your current anticoagulant therapy. In many cases, the answer will be no. That single question could eliminate a meaningful and unnecessary bleeding risk from your daily routine, starting at your very next appointment. Combination 3. Sleeping pills and blood pressure medications. This one is quieter, more insidious. And I say that as someone who has seen its consequences show up not dramatically, but slowly, in patients who keep reporting dizziness, falling, confusion, and exhaustion they cannot explain. Benzodiazepines and related sleep medications, diazepam, lorazepam, temazepam, zolpidem, are prescribed widely for insomnia and anxiety in older adults, despite significant evidence that they carry disproportionate risks in this age group. The body after 60 clears these medications slowly. What sedates you for 4 hours at 45 may still be active in your system 8 hours later at 70. When combined with antihypertensive medications, the interaction operates on 2 levels. First, many blood pressure medications already carry a mild sedative or dizzying effect, particularly alpha blockers like doxazosin and some beta blockers. Add a sleep medication on top, and the sedative burden on the nervous system compounds significantly beyond what either drug produces alone. The result is excessive daytime drowsiness, slowed reflexes, and impaired balance. But here is the cardiovascular piece that rarely gets discussed. Benzodiazepines can cause a drop in blood pressure, particularly when standing up from a seated or lying position. This is called orthostatic hypotension. In a senior already taking medication to lower their blood pressure, this drop can be dramatic. The brain receives insufficient blood flow for several seconds. The person feels dizzy, reaches for something to steady themselves, and falls. Falls in seniors over 65 are not minor inconveniences. Hip fractures following falls are associated with a one-year mortality rate of up to 30%. I do not share that statistic to frighten you. I share it because the chain of events that leads there so often begins with a medication combination that a doctor prescribed in good faith without fully accounting for what was already in the medicine cabinet. If you take a sleeping pill and a blood pressure medication, this conversation deserves to happen at your very next appointment. Combination 4. Statins and certain antibiotics or antifungals. You almost certainly know what a statin is. Atorvastatin, rosuvastatin, simvastatin. They are among the most prescribed medications on the planet, and for adults over 60 with elevated cholesterol or cardiovascular risk, they are frequently a long-term fixture of the medicine cabinet. What most seniors do not know is that statins are processed by the liver through a specific enzyme pathway called CYP3A4. And certain commonly prescribed antibiotics and antifungal medications use that exact same pathway. When both are present in the system simultaneously, they compete. The antibiotic or antifungal blocks the enzyme that normally breaks down the statin. The statin cannot clear the system at its normal rate. Its concentration in the blood rises, sometimes dramatically. The consequence of elevated statin levels is a condition called myopathy, muscle damage. It begins as unusual muscle aching or weakness, easy to dismiss as the normal soreness of aging, but far more serious than it appears on the surface. In severe cases, myopathy progresses to rhabdomyolysis, a breakdown of muscle tissue that releases proteins into the bloodstream that the kidneys must filter. In a senior with already reduced kidney function, this can trigger acute kidney failure. The antibiotics most commonly involved in this interaction include clarithromycin and erythromycin, both widely used for respiratory infections. The antifungals include fluconazole, commonly prescribed for fungal infections. These are not obscure medications. They are prescribed regularly, often by doctors who may not have your full medication list in front of them at the time of prescribing. The practical step here is straightforward. Anytime a new antibiotic or antifungal is prescribed to you, tell the prescribing physician that you take a statin. Tell them which one and the dose. Ask directly whether there is an interaction and whether your statin should be temporarily paused during treatment. In many cases, a simple temporary pause eliminates the risk entirely. This is a 5-second conversation that most seniors never know to have. Combination 5. Diabetes medications and certain blood pressure drugs. This final combination affects a significant and growing population of seniors because the overlap between type 2 diabetes and hypertension after 60 is enormous. Many seniors manage both conditions simultaneously, which means many seniors are taking medications for both simultaneously. The interaction I want to focus on specifically involves beta blockers, metoprolol, atenolol, carvedilol, combined with insulin or sulfonylurea diabetes medications like glipizide or glyburide. Here is the danger. When blood sugar drops too low, a condition called hypoglycemia, the body normally triggers a set of warning signals: shakiness, sweating, racing heart, anxiety. These symptoms exist specifically to alert you that something is wrong so you can eat something and correct the problem before it becomes serious. Beta blockers suppress many of those warning signals. They slow the heart rate. They blunt the adrenaline response, which means the warning system your body relies on goes completely silent. Which means a senior taking both a beta blocker and an insulin-based diabetes medication may experience a dangerous drop in blood sugar and feel almost nothing. No racing heart, no obvious shakiness, just a quiet slide toward confusion, weakness, and in severe cases, unconsciousness. This is called hypoglycemia unawareness. It is well documented in medical literature, and it is a genuine emergency risk in seniors managing both conditions. The brain is almost entirely dependent on glucose for fuel. A prolonged drop in blood sugar is not just uncomfortable, it can cause permanent neurological damage. If you manage both blood pressure and diabetes with medication, this specific question deserves a direct conversation with your doctor. Ask whether your beta blocker could be masking hypoglycemia symptoms. Ask how you would know if your blood sugar dropped dangerously while taking both. Ask whether a glucose monitor at home is appropriate for your situation. These questions are not overcautious. They are exactly the right questions for someone managing two serious conditions at the same time. I want to come back to Margaret for a moment. After that 40-minute review in my office, we made 3 changes. We replaced her ibuprofen with a topical anti-inflammatory gel for her knee. We adjusted the timing of one of her blood pressure medications. And I wrote a single letter to her general practitioner summarizing everything, so that her full medication picture was finally in one place, visible to everyone treating her. 6 weeks later, she came back for a follow-up. Her kidney markers had normalized. Her blood pressure was stable. Her hands were steady. She sat across from me and said something I have thought about many times since. She said, "I trusted that someone was watching all of this. I assumed the system had it covered." That assumption is one of the most dangerous things a senior can carry into a doctor's office. Not because doctors are careless. They are not. But because modern medicine is specialized and fragmented in ways that make it genuinely difficult for any single physician to hold the complete picture of a patient taking multiple medications. Here is what I want you to do before your next appointment. Write down every medication you take, prescription and over-the-counter, every supplement, every vitamin, every occasional painkiller. Bring that list to every appointment with every doctor you see. Not just your primary care physician, every specialist, every urgent care visit, every pharmacist. And ask these 5 questions. 1. Do any of my current medications interact with each other? 2. Are any of my medications processed by the same liver enzyme pathway? 3. Given my kidney function, are any of my current doses too high? 4. Is there anything on this list that I no longer need? 5. What symptoms should I watch for that might signal a medication interaction? These are not aggressive questions. They are not confrontational. They are the questions of an informed patient who understands that their body, after 60, operates by different rules than it did 20 years ago. Any physician worth their time will welcome every one of them without hesitation. Let us bring it all together. Because I want you to leave here with clarity, not anxiety. 5 combinations that become genuinely dangerous after 60. 1. Blood pressure medications combined with ibuprofen or naproxen. The risk is kidney damage, sometimes rapid. The fix is a conversation about safer pain relief alternatives. 2. Blood thinners combined with daily aspirin. The risk is serious internal bleeding that builds slowly and silently. The fix is asking your doctor whether the aspirin is still necessary. 3. Sleeping pills combined with blood pressure medications. The risk is dangerous blood pressure drops, falls, and fractures. The fix is revisiting whether the sleep medication is still appropriate. 4. Statins combined with certain antibiotics and antifungals. The risk is muscle damage progressing to kidney failure. The fix is always disclosing your statin to any doctor prescribing a new antibiotic or antifungal. 5. Beta blockers combined with insulin or sulfonylurea diabetes medications. The risk is silent hypoglycemia with no warning symptoms whatsoever. None of these fixes requires a new prescription. None of them requires a specialist. They require one thing: a conversation. An informed, direct, unhurried conversation with your doctor, armed with the knowledge you now have. Margaret had that conversation 6 weeks too late. You are having it right now. That is not a small thing. That is everything. And if someone you love is over 60 and taking multiple medications, share this video with them. That one share may be the most important thing you do today. Take care of yourselves. Stay informed. You deserve a medical team that sees the full picture. And now, so do you. One last thing before you go. Earlier in this video, I mentioned the free Senior Patient Toolkit available at seniorsaids.com. It is always in the description below this video and every video on this channel. 2 pages, a medication interaction checker card, and a word-for-word doctor's appointment script. Completely free, 30 seconds to download. If this video helped you think more clearly about your medication list, that toolkit is the practical next step. It turns everything you just learned into something you can bring into your next appointment. The link is below. Get it before you close this tab. Everything shared in this video is general medical information based on current published research and clinical experience. It is not a substitute for your personal medical care. Before making any changes to your medications, please speak directly with your own physician. They know your history, your body, and your full clinical picture. This video is the beginning of a conversation, not the end of one.